Right, as we talked about it, so the ECHELON-2 is a randomized study. About 225 patients or so received CHOP. There was a blinding piece to it during the randomization. The CHOP, which is the cytoxin, adriamycin, vincristine, and the prednisone, or the cytoxin, adriamycin with no vincristine, prednisone, and brentuximab vedotin. And patients received 6 cycles of either, and then went on, if they were transplant eligible, would be evaluated for transplant, go on to get a high dose therapy with stem cell rescue, and there was a maintenance component to it for up to a year. So they would receive brentuximab every 3 weeks for up to a year. And very well done. So the components of the study not only had this comparison, also had the question of transplant and the maintenance piece as well. And as mentioned earlier, there's not only the PFS and the survival advantage of the CHP arm, but it also evaluated the question of transplant. And so if you look at the transplant, about 22% of the patients in the CHP arm went on to receive a transplant, and about 16 or 17% in the CHOP arm. We would always talk about every patient T-cell lymphoma going on to transplant. This is sort of the reality piece, reality check, if you will. Even in a study like this, a robust study like this, only 1 in 4 in the CHP arm and less than 1 in 5 in the CHOP arm went on to receive the transplant. And so we talk about transplant, but then only a few of them made it. And then if you look at the maintenance part, the ones that receive the maintenance, overall, the strategy I think is going to be the standard of care. It's a game changer for T-cell, CD30 positive T-cell lymphomas.